Thank you. I think a lot of my talk has already been taken by Dr. Bhagwat and Dr. Devang, so I'll rush through it. Um, Basically, the idea of this talk was to say that, children come to us when they're a couple of weeks old, but they are going to get to be 20, they're going to be 40, they're going to be 60 years old. So whatever we plan, we have to think that, this is something that is a long-term solution to a very major problem. And we can't do it on our own. It has to be something that has actually been experienced over time. So whenever we look at literature, we want to know, why are we trying to set this target IOP at all? And in children, keeping this longevity in mind, what we want is to start by actually causing a reversal of any damage that may already have occurred. Or if we can't do a reversal, at least to stabilize the optic nerve head. We want the best possible corneal clarity. We want to make sure that the eye doesn't enlarge anymore and we don't end up with people having -20, -24 myopia. We want to stop it as early as possible. We want the best visual acuity, which is not always in our hands because there may be associated developmental anomalies. We also want a very stable perimetry. What we do know and what literature teaches us is that because of the elasticity of the ocular coats, it is possible to return everything towards normality if there's a significant fall in intraocular pressure. So we've gone through the normal IOP, and I would just reiterate that, it tends to be between 10 and 12 millimeters of mercury. There are many differences in children's eyes as compared to adult eyes. The IOPs that these children come to us with are sort of 30 plus. They all have a very large disc size because of the stretching of the coats. They have corneal opacification, very large corneas, very thin lamina cribrosas. There's a huge asymmetry between the two eyes, which leads on to more visual problems once the intraocular pressure is controlled. And as I'm repeatedly saying, the longevity that we have to take care of. What are the challenges? That by the time the children come to us, they already have pre-existing structural damage. I think the large cornea is something that everybody sees immediately. But associated with that, you have a Descemet stare, and then you have some haze. And just the haze is enough to cause a difficulty in visual acuity later. Increased in the axial length, the associated developmental anomalies like iris hypoplasia, aniridia, fundal problems, they're all pre-existing and we have to work around them. We also have to be aware that children actually grow with time, not only as far as their body is concerned, but as far as the eye is concerned. And these age-related changes have to be differentiated from the IOP related changes. So if you have an IOP which is sort of 20 and it's going to cause some sort of increase in the axial length, some increase in the corneal diameter, this is going to be additional to what is happening with normal growth. We also have problems in assessing the functional sort of damage that we start with because we can't assess vision perimetry. A strabismus is a very common sort of occurrence in these patients over time. And when we look at the therapy of these patients, we need frequent examinations under anesthesia. We know that children have a very poor response to medications as compared to adults. There's a difficulty for the mothers to put the drops. They may need additional cataract or keratoplasty. So keeping all these in mind, what have we learned over the years? This young boy up there, he was one of the patients in whom we did a trabeculectomy with trabeculotomy, but without mitomycin. At that time, we were under the impression that a pressure of 20, 21, anything less than that was acceptable. But you can see the high myopia that he has when he has reached the age of 22. On the other hand, this girl, we operated with mitomycin C, and you can see that the intraocular pressure is much lower and she actually has no need for glasses, at least for distance. So the CGRN classification has given us primary, secondary, and other things, but it hasn't said what is the aim of treatment. And most of the papers you will find will be talking of less than 21, except for this one paper, which is quite old, 1999. So again, when we looked at our patients, 174 eyes or 108 patients, what we found was that a cup disc ratio of minus of 0.5 or less than 0.5 could be achieved with a mean IOP of 10. Reversal was seen only in those eyes where the IOP was 6 to 12. Stability was seen between 6 and 12. And anybody who had an IOP of more than 16 ended up with progression. So keeping this in mind, remember that an IOP of less than 15 probably is the ideal that we should aim for, and anything more than 15 would be more likely to cause problems. But just to put it all together, there are preoperative, that are structural damage that has already occurred. That means in the older children, there's the chronic rise in IOP, a very high IOP, they already cause problems to the optic nerve. So that with surgery, all we can do is lower the IOP, and this lowering of the IOP actually can reverse a lot of the cup disc changes and also reverse to some extent what is happening with the axial length. So visual field effects, what we found was that they were much better in patients who had less than 15 millimeters of mercury in the long term and worse with more than 15. And these are many studies that have been done around the world, which say that if you look at 19 to 22 millimeters of mercury in children, you will find there's no reversal or actually progression. And a similar kind of thing can be seen with refractive errors, that the mean refractive error, if we kept the IOP less than 15, was -2, as compared to, as I said earlier, when we were thinking 20 and 21 was good, supported by a lot of studies, including from Dr. Mandal, you can see is fairly high. So I think we have to be aware of what our target IOP is, and it should be less than 15, but also dependent on the cup disc ratio. So if the cup disc ratio is more than 0.8, make it lower, and if it's only 0.7. Similarly, with secondary glaucomas, you must lower the IOP to at least the age normal, and less if the optic nerve is significantly damaged. I'm not sure why that timer is going off.
I'm so sorry. I'm so sorry, Dr. Ramanjit. There was some technical error. You please go ahead. I'll take care of it.
All right. Okay. So if I can go back a couple of slides, I think most of our surgeries are actually now much more successful than they used to be. So I think we can reach these. So just a little bit of emphasis on the secondary childhood glaucomas, because they are fortunately, a lot of them are iatrogenic because of the steroids we give, because of the surgeries we do following trauma or following a corneal infection. So a high index of suspicion for a raised IOP, early diagnosis of the raised IOP, and a control to normal levels would prevent any optic nerve head damage at all. So if you find that the medication is not allowing you to reach the requisite IOP, you must control the inflammation, think about the fibrosis that has already occurred in an eye like a traumatic eye, and operate only on a quiet eye. Lower the IOP, as I keep saying, to the age normal, and if the optic nerve is significantly damaged, to lower than the age normal. Always evaluate the fellow eye for glaucoma, because secondary glaucomas occur in eyes that are predisposed. So just a couple of cases. This is a child with primary congenital glaucoma. We operated at 1 month of age. The child is now 18, and you can see the review IOPs have been consistently between 10 and 14. And our OCTs, our HRT, and the fundus shows us that the neuroretinal rim is absolutely normal, and these fields in both eyes are absolutely normal. But because there was a difference between the right eye and the left eye as far as the stretching of the cornea is concerned and the axial length, there is an anisomotropic amblyopia. This is another child with axon field rigors. Unfortunately, came to us very late, so we only operated at 11 years of age, by which time, as you can see in the left eye, there's already a significant damage to the neuroretinal rim inferiorly. You can see the damage on the OCT, you can see the same damage on the HRT, and this is her visual fields. But we have an IOP now of 10 millimeters of mercury, and I think that should actually stabilize the optic neuropathy and prevent any further progression. So the appropriate target IOP has to be maintained lifelong. If we want to get clear corneas, very low myopia, and a reversal of the cup disc ratio. And as I said, These days, our surgeries are much better. They are safer. We have more medications available to us. And I think this is definitely a very strong possibility in almost all children. I'd like to thank all the people, as you can see, this entire team from RP Center for all the studies that we have done. Thank you.